Hello, everyone. I want to welcome you back to class. Um, we have a really remarkable group of guest faculty today, but I thought it would just be really not possible to start class today without briefly reflecting on where we are in the pandemic. And as almost all of you have heard, just this morning in the last 2 hours, the United States surpassed 200,000 deaths. And I have found that a difficult number to understand and to try to grasp what its meaning is in terms of loss and grief and our ability to respond effectively and humanely to the pandemic. And I noticed this morning when I started reading that commentators have tried to figure out how to put their heads around a number like 200,000. I'm a Red Sox fan, often at Fenway, although not recently, obviously. And Fenway seats about 34,000 people. Some of us have been there in the very exciting games when the place is full, but it occurred to me this morning that it was 6 stadiums filled with fans that have died just in the last 8 months in the United States. I then went to Wikipedia, and Wikipedia is good for some things if you want to know the populations of different cities. 200,000, and there's a long list of cities in the United States that have 200,000. That's Rochester, New York, Salt Lake City, Montgomery, Alabama, Little Rock, Arkansas, Tallahassee, Florida, and actually Providence, Rhode Island is just under 200,000 inhabitants. So these are gigantic numbers. They constitute a loss for literally millions of families around the United States. The numbers across the world are equally dismaying and upsetting. Now we've had 300 million cases around the world and a million deaths. So there is this way we're diving deeply into trying to understand what's going on and the character of the pandemic. But at the same time, I think in the midst of a pandemic, we need to pause every so often just to reflect on what its meaning is, what the experience is like, and how it's changing our lives and our world. I also just wanted to briefly say that this is it's a week of mourning for Ruth Bader Ginsburg, who was one of the most important people in the history of our country, second woman on the Supreme Court, and the first woman since 1873 to argue a case in the Supreme Court, and she'll be the first woman to officially lie in state in the Capitol Rotunda this week. And it just is a reminder of the really remarkable obstacles to women in our societies and around the world and what she was able to achieve for equality and social justice. So I can't help, the course is moving on and moving fast, but I wanted to note those incredible losses and to remember what they mean to us. Today we're going to be talking about testing. As I said, we have a great group of faculty. We have 2 polling questions that we wanted to pose to you before we turn to today's speakers. So Yvonne, could you put those up? That is just so interesting. Almost half the class has been tested, and that would be tested before students return to campus. Those of you who are on campus have obviously already been tested multiple times, but we were curious about your interaction with the testing and the testing system since you left school in March and have started back. So let me turn it over to Ingrid.
Thank you so much, Alan. As Alan mentioned, we are so thrilled about today's class. We have three phenomenal speakers. Really just couldn't be happier to be learning from these three today. And I would say I get questions on the daily about testing, and I'm certainly not a testing expert. So these three people are going to be providing a phenomenal education for us as we move through this conversation. And as we all know, really, the technical ability to test for and diagnose an epidemic disease has really been a crucial aspect historically of a public health and medical response. Without testing, we really don't know what we're dealing with. And we have seen that play out in really remarkable ways in the United States. And many people would say, including myself, that we still aren't where we need to be with testing. But obviously, you know, testing, for those of you who are on campus, and we know that's a minority of this group, is a crucial part of physically being here. And this class today is really going to explore the science and technology of testing, as well as the problems and possibilities that testing may offer, and of course, the US response in this epidemic. So without further ado, I'm going to introduce our three speakers today. As is our routine, we'll have each speaker speak sequentially, and then we will bundle questions at the end. And again, we'll make sure we try to leave enough time for our questions. We have such great questions from you all. So I'll do a quick introduction. Starting us off today is Professor Pardis Sabeti. For those of you, for the 4 people in the world who don't know Professor Sabeti, she is a professor at the Center for Systems Biology and Department of Organismic and Evolutionary Biology at Harvard, and the Department of Immunology and Infectious Diseases at the School of Public Health, and a Broad Institute member. Her lab has done key research that has spanned from developing analytic methods to detect and investigate evolution in the genomes of humans and other species, to examining host and viral genetic factors of driving disease susceptibility, and has been deeply involved in outbreaks including Lassa hemorrhagic fever and Ebola virus. And she has been a critical member of this conversation around testing to the COVID response. My favorite snapshot of her was an article, I believe it was in the Crimson, that said Dr. Sabeti is in great demand for her work, which seems prescient, and she might say that's because we haven't been paying attention. So I think that was a great quote, and we'll look forward to hearing from Professor Sabeti. I'm just going to introduce our other 2 speakers as well while I'm here. Dr. Margaret Bourdeaux, who trained with me at Brigham and Women's Hospital, who I know very well. She is the research director for the Security and Global Health Project at the Harvard Belfer Center at the Harvard Kennedy School. And she's also an associate physician at Brigham and Women's Hospital. And she conducts research and fieldwork focused on health systems and institutions in conflict-affected states. And we are so excited to learn from Margaret today about the US response in this global pandemic. And then our third speaker today is Dr. Michael Mina. He is an assistant professor of epidemiology at the Chan School of Public Health and a core member of the Center for Communicable Disease Dynamics, or CCDD. He has been a very active voice in multiple forms of media around testing, and has been really a leader in discussing how to move testing forward, what types of tests are critical right now. He has a wonderful blog that we can try to put up on the screen for those of you who, or podcast, sorry, who, for those of you who might be interested, especially for those of you as you're thinking about making your own podcast. So we will be hearing from our speakers in that order, and we will welcome Professor Sabeti to come and speak with us first. Thank you so much.
Great. Well, thank you so much. I'm really excited to be here and love speaking to the undergraduates. I was really excited when Alan and Ingrid asked me to participate in this course. And I just want to say congrats to you all for taking kind of a brave move in the middle of this pandemic to say, I want to double down and I want to learn everything I can about what's going on, and to Alan and Ingrid for making this course happen. And I think, to me, it's really important that infectious diseases are unique in 3 ways. One, they cause more deaths than all the wars that we've had in the past, yet they get a fraction of the DoD budget. What you need to actually stop a pandemic is what you need to stop Janice down the hall making you sick during cold season. And so the practical steps are actually really useful, and are things that we should be able to do. And we don't have to say, hypothetically, this is a risk. It actually stops infections spreading generally. And then also, unlike other existential threats to humanity where you say, hey, you can make a difference, you know, if you vote or if you recycle, it's hard to actually make that statement really be true. I mean, if I don't recycle, what impact am I really having? But in infectious disease, because of the exponential growth, every person actually matters. And one person could seed a pandemic and one person could stop it in the same way. So I think from that standpoint, really excited that you're here doing this. I'm going to share my screen and just show a few slides that is around, you know, how I think about pandemics in the diagnostic space. Oops. And it's just to reflect. So there are 3 kind of key things that we think that are needed for a pandemic. It's the ability to detect it, connect information in real time, and to empower reactor in the system. So what does that mean? Well, we need to be able to have point of care tests that could be used in your home, ideally, but if not, in a village or in remote clinics. At hospitals, we need to be able to test for a number of things. I just knocked my cat off. If anyone saw that, I apologize. I either let him interrupt and then he starts to harass me, or I push him off and look like animal abuse. So he's back, and so he's staying. And then genome sequencing, the ability to detect new threats and to characterize them. And then we need to be able to connect that information in real time so that any cluster of cases we see somewhere will be known anywhere, and we can start to identify trends. And not just within that network, but within these sites, but engage and connect every person in the system, a way of connecting every actor, and then to empower every actor in that system. And that's essentially what is needed. And in the last decade, we've really started to see that that's possible. With genome sequencing, we could quickly sequence the virus, identify all the different threats that were, all the different versions that were emerging, and start to characterize something that's transmission. In Zika, started to see that we could be able to do rapid point of care tests, ones that could be used from non-invasive samples like urine and saliva, and could be read out. And so could we get really, really fast? And that those technologies are nascent, but they're possible. And then I'm going to just take a moment and talk to you a little bit about the mumps epidemic here at Harvard, because I think it's so telling, and it speaks to a little bit of the experience of those who are on site now, or those who may be on site in the future. You know, I was in panel during every outbreak of, previous outbreaks like Ebola, but we also got a call in the spring of 2016 when mumps started showing up on the sports teams. And then from there, it popped up in the residential colleges where roommates were infected. Freshman dining hall, they identified that as a hotspot because some staff were infected and faculty who were eating there. Health services, where 3 nurses became infected. And then a commencement event that I'll tell you a little about in a second. And generally, when you think about it, college campuses are laboratories for infectious spread because of the way that residences work, and we eat together and we sit together and we're moving around in a small community. And Boston has 110 of them, of little laboratories, but there are also places where we can really start to understand how outbreaks spread. And we partnered with all of these different schools in 2016 and 17, and with this really cool collaboration to understand the spread. We sequenced the virus, and we could actually use the sequence of the virus to track what was going on. And there are multiple strains of mumps that were circulating. Interestingly, this is an interesting standpoint where there was a community outbreak in East Boston, an immigrant community that was largely unvaccinated to mumps, thought to be independent, but when we did the sequencing, it showed that the virus actually came off of the Harvard strain. And going back to the data, actually 3 of these individuals had Harvard affiliations, we found. And so this is something that the genome sequencing data could tell us that the epidemiology missed at that point, but could have seen. And if you look on the left, that's what traditional epi is doing to create transmission links to understand who infected whom. People went around, made phone calls and said, who have you been in touch with? and found links between individuals. And on the right is what the genome sequencing tells. And the important point here is that the traditional epidemiology is actually very accurate. Every link that was found by the traditional epi was confirmed by genomic sequencing, but it missed so much. And this tells you how important it is to get faster, both with the ability to identify cases, detect them, but then also to share that information in real time. And so that sort of larger frame of how we think about it is to have different kinds of technologies across the piece, having mobile technologies and platforms to share that data, and then making sure that data is constantly feeding back. That's the way we need to be thinking about this. And these technologies are becoming available. And they were kind of moving. We were in a bit of a renaissance of being able to develop this kind of technology when COVID hit. And I'll just show you some things from my own experience that tell you why this is important. This is, this being able to test is really critical. Being able to test when asymptomatic infections are common and asymptomatic spread is common is really critical. This is data from the early days of the Boston outbreak. It actually misses most minorities because minorities were less likely to be tested, and only certain individuals, wealthy individuals, were more likely to be tested. So this is not describing the Boston outbreak in the early days. This is the Boston outbreak we could see. And what we see here is there's an outbreak at a conference that happened, an international conference that happened in late February. And it actually diverged. There was like 2 events, and a mutation allows us to track the divergence of these 2 strains. And then in all red here that you see the close-up here, that's outbreaks in the homeless population. This is Boston Healthcare for the Homeless. And what is really striking about this is that these outbreaks went on to cause potentially tens of thousands of infections, but major outbreaks in the homeless community. And the reminder here is asymptomatic spread is a driver of disease in COVID, but that the vulnerable amongst us are disproportionately hit. And so it just tells us what we need to do. And the kinds of technologies, I'll just show you the kinds of technologies that we're developing. Here's one that's a CRISPR-based assay. Many people are developing assays like this, but this is just the kind of example of molecular tests or antigen capture tests that can work from saliva, be read out quickly, and read out either in fluorescence or on paper. So these are these kinds of point of care assays that you could maybe read with a mobile phone. And that's actually Abbott recently had an antigen capture test that also they paired with a mobile app. So this is being able to do testing on the ground. We're excited about also the ability to test for lots of different things. Most of the time when you're infected with, for I guess the vast majority of COVID cases or suspected COVID cases, test negative, or always the majority and sometimes the vast majority. And so these are kinds of technologies that we're working on to be able to test for lots of different viruses and lots of different samples simultaneously, so that the next time you come in, you don't have to know what you have. You could just run through a series of respiratory viruses or the like. And these are the kinds of things we want to be seeing in hospitals. And then we need to be able to have general kinds of dashboards and lots of, the thing is there's a renaissance happening right now, and I'm just showing you some examples from the work we're doing of developing mobile apps that can then pair and be able to show you real-time dashboard information around cases. This is an image from the Harvard campus, but the kind of, these other ones are actually live, oops. But this particular one is one that's an example. I think actually with time, I'm not going to kind of get into some of the other things, but this is just a snapshot. I know we want to be able to have a rich conversation. I think though, I guess maybe the only last thing I'd say is it's never too early to think about how to respond to a pandemic. This is an image from a course that we run for the last 5 years at a middle school in Florida, where we spread a virtual virus via Bluetooth on your cell phones and are allowed, and the kids actually practice stopping a pandemic. We even have QR codes where they can run diagnostic tests. We give them a certain number of diagnostic tests, and they have to choose who's, like this person's sick, do they have COVID? We don't know. So you could choose to figure out what's going on. And the cool thing about that is in this case, you actually see the ground truth. This was a SARS-like virus being spread, and you could see what would happen in these communities. And that's a little bit of like where I'm just excited that you guys are participating in this education, is that there's lots of ways of preparing ourselves for outbreak response, and we should take every opportunity. With that, I just want to thank you and remind you that all of this is just important, and what motivates me every morning is the kids around the world who are at home or at risk or not able to come to school because of what's going on. And so you all motivate me, and I think you guys are part of the solution. And so thanks for being here. All right.
Thank you so much, Professor Sabeti. Why don't we move on to Dr. Bourdeaux, and then we'll bundle all of our questions for a rich conversation at the end. That's okay? Okay, great.
Sure. Thank you. Thank you so much. It's such an honor to be here. And I think as Professor Brandt and Professor Sabeti mentioned, this is a very, very profound moment for most of us who are speaking about this subject. And I think it's sort of must be interesting, as students. I was an undergraduate at Harvard, and I took many gen ed courses, and I think about them actually all the time and things I learned in them. But I'm not sure that I ever took a class where I would say that the folks that were teaching it, were so in the midst of probably one of the biggest, thing that's happened in their professional careers and in their personal lives. So I'm so pleased that you guys are tuning in and showing up to share really in this moment. I'm going to do the bold thing of sharing my slides, see if I can make this happen. In a granny kind of way. Okay, is that working? Okay. Yeah. So as Ingrid mentioned, I'm a faculty over in the Division of Global Health at Brigham, and most of my career has really been spent thinking about health delivery and health systems and institutions in conflict-affected places. And so, one reason this is such a profound experience, this outbreak, is because, now my work has really pivoted to looking at and to working on COVID response, specifically here in Massachusetts. And the program that I run at the medical school has served as sort of a policy advisors, translator for Partners in Health, which is an NGO that's working on contact tracing with the state of Massachusetts. And so I've had a little bit of a, I wouldn't say a front row ticket, but a second row ticket to some of the delivery issues with respect to COVID response. And today we're talking about the testing delivery. So, what the heck do I mean by delivery? And this concept of health delivery is something that really concerns a lot of folks in my department, that really, because, essentially arising because of the experience of working around the world and seeing that, humanity had developed all of these amazing interventions and technologies and cures and treatments, and yet so many people lacked the ability to access them. And so, the shorthand lesson that I think we've all sort of taken forward that summarizes this idea is that, we like to say, vaccines have never saved a single life. Vaccination has. It's vaccination, it's the action. In this case, a test has never diagnosed COVID. Testing diagnoses COVID. And that has to do, with delivery. I think the other sort of thing that when people hear delivery, they immediately think about logistics, like this photograph from the UNICEF website of a vaccinator, the logistics of carrying a vaccine into a rural area in India. It does have to do with logistics, but it's a broader issue. In that, what I like to call it, delivery is about discovering and mapping the invisible architecture of a health, of a logistics system, or of a health intervention. So if you're, one of the cool kids that thinks a lot about this in the world, not me, but others have thought deeply about what does delivery mean and how should delivery be sort of thought about with respect to health interventions. They have a little framework that I'd share with you. I think it's a useful kind of rule of thumb when you're trying to indeed discover and map the invisible architecture of a health intervention. And they call it triple AQ. But basically the first question you ask is, okay, what is the goal of the health intervention? And then triple A refers to the three A's. Is it accessible? Is it affordable? Is it acceptable? And is it of sufficient quality? So just to think a little bit about this in the context of testing for COVID. So, for the purposes of this discussion, even though there's a lot of different modalities of testing, in general, we've relied on PCR testing, one specific type of testing to diagnose COVID. And so when we think about the AAAQ, sort of starting up in this, in the upper left with accessibility, a lot of folks think about it in terms of geography, like where is that test, being offered? And that is definitely part of it. But there's a whole other set of questions you could ask about accessibility. Who can get the test? How are they authorized to get the test? Who authorizes them? Do they meet criteria for testing? Of course, where is it offered? But where is the lab that actually runs the sample? How quickly can they report the sample? Then with respect to affordability, this is about who pays and also just like who bills the payer, very practical kind of things. With acceptability, a lot of us, if you have been tested, you probably received an NP test, the tickling your brain approach to testing, which is like not all that appealing. But acceptability sort of covers a broader range. It's not just how fun is the test to have done or how uncomfortable is it, but it's also, it speaks to a larger point about why might people not want to get tested? And I think a lot of us have probably had an experience over the last couple of months where we thought it might just be in our best interest to not know whether we're infected or not. And that sort of falls under the rubric of acceptability. And then in the last quadrant is quality, and that has to do with, does it help you achieve a public health goal, or does it help you achieve a personal health goal? In this case, does it make the diagnosis for an individual, and does it help advance our understanding of what needs to be done from a public health perspective to control and eliminate the epidemic? I want to give you three sort of snapshots in time over the epidemic as it's played out in Massachusetts and highlight some of these issues around, AAAQ that came up with respect to these three time periods. So the first one, and I chose time periods and little snapshots where the actual cases were low, but the considerations around delivery were radically different, I found. And so the first one, of course, is at the very beginning here in Massachusetts, March 13th. We hadn't diagnosed a lot of COVID. And it was a very scary moment. Panic was spreading probably as fast as COVID was, particularly among the healthcare providing community. And there were many, many, many different concerns. But the one that really sort of floated to the top and seemed the most urgent was the protection of our health workforce and protection of and keeping our hospitals from becoming drivers of the epidemic. And so testing, the conversations around testing started to really focus on that particular goal. But thinking about sort of accessibility, just to run through it. Okay, so who was going to get tested? In order to achieve that public health goal, it was largely folks with a travel history and symptoms who were moderately to severely ill, who generally were showing up at hospitals and acute care settings. And there were a whole bunch of other things. They needed to have an ordering physician, wasn't hard in a hospital. Hospitals had to have testing kits. And of course, there had been this big bungling of the test that the CDC had developed. And so everyone was behind. The CDC was behind on getting a test to hospitals that they could use to test patients. Then when they did deliver the test, there was a whole brouhaha over the actual materials, to collect the sample from the little nasal swabs and cotton strips to, the viral transport medium, a whole lot of concerns about materials. And then, then the concerns about affordability. So, there was hope that you wouldn't be charged for getting a test, for showing up to a hospital and getting a test. You could, if you had insurance, it would be billed. And eventually the state, did stand up and say, we will cover those costs. Acceptability, the test was in high demand, even though it wasn't necessarily the most pleasant thing. In terms of quality of the test, yes, I mean, once the test, PCR test got formulated and made and distributed, they were high quality in that they were allowing us to see who was infected in the hospitals. But here's what happened. The upshot of that experience was that our laboratory capacity expanded in our hospitals and in the commercial laboratories that were running all sorts of medical tests. Those companies, were running lipid panels and, blood sugar screenings, everything like that. They built up their capacity to run COVID tests. So then then the infection, the outbreak grows tremendously. We are able to, quote, flatten the curve by, instituting lockdown measures. The other thing and we did, achieve our goal of not having our hospitals overwhelmed or becoming drivers of the epidemic. The other thing we did really at the peak here was in Massachusetts was stand-up contact tracing. And contact tracing is a public health a strategy where you do try to go and find and delineate different chains of transmission and interrupt them, figure out who's infected, figure out who they've been in contact with, keep them, and try to keep them away and from spreading the infection onward. So we started to build that up. That's a whole, chapter of my memoir, how that unfolded. But we had some nice success. The hospitals weren't overrun. The contact tracing program did start. And the purpose of contact tracing really is to try to achieve another public health goal, which is to try to end community transmission or interrupt community transmission before people get to the hospital. Okay, so we were feeling pretty good because we'd done that. So how did we do it? We got the clinics and the community health centers to offer testing. Okay, so we were all feeling very good. People could show up at their doctor if they'd been exposed. Everything was just seeming to be like not great, but okay. All right, well then we come across point 2. So we and the contact tracing program is feeling very confident. Well, then we start to hear reports that actually the tests are being conducted. Yes, the primary health care clinics that we're working with have testing kits and they're submitting them, but they're not getting the results back. Well, why were they not getting the results back? And we're talking delays of, 7 days, 14 days. These are outbreaks that have, intended to be in poor communities where, 100 people had died. And they were trying to get a hold of it. And the public health nurse was like, oh my gosh, I can't get a result on who's infected. And so we started to dig in, well, why was that? Well, it turned out that some of the things that were going on around the country were impacting Massachusetts. So even though our curve looked like this beautiful thing, nice and flat, other places in the country, the cases were rising pretty dramatically. And in particular, very populous states, California, Florida, Arizona, Texas. Well, why was that impacting us in Massachusetts? Because of the choices that we made to build out our reliance on our commercial laboratory tests. So it turned out that the clinics in Massachusetts and many actually of the hospitals as well were relying on the big commercial laboratories, Quest and LabCorp, among others, to run their tests. Well, it turns out those were national companies, and they were also running tests for other people in other states. And so this was a very rude awakening for us, where all of a sudden we realized that we were very heavily tied into the commercial lab and reliant on the commercial labs and the private sector. So, we were achieving our public health goal, but all of a sudden we were like, we're not going to be able to stop community spread because we don't really have access because our testing architecture, the invisible architecture we hadn't understood is not where it has a flaw in it. And so accessibility became this funny, the definition kind of changed. All of a sudden we had people who had access to the testing kit, but they didn't have access to a lab that could run it in a timely manner. And so then to go through the others, the affordability, insurance was kind of paying by now, and the state was covering costs, that was okay. And the acceptability and the quality sort of remained high. But the upshot was that we were in a real pickle here because of the decisions that we had sort of made, and we didn't even know we were making them at the beginning. So which brings us to kind of the current moment, if you will. So right now, so what kind of happened? How do people deal with that? So essentially what happened was folks said, okay, in Massachusetts said, okay, we're going to try to unwind our reliance on these commercial labs, and we're going to turn to other academic and research labs to be able to send samples to run. And the big player in this to date has been the Broad Institute. It has said, kind of offered to kind of try to fill this role. The alarm that I felt over the summer and still feel has a little bit to do with that choice, because what we are sort of seeing is that we all of a sudden are having public health goals start to compete with one another. So we still have the public health goal of stopping community transmission. But there's another goal that a lot of others have in communities where infection rates are very low, which is to roll out screening and surveillance testing for folks like, well, Harvard undergraduates to make sure that we catch outbreaks sooner rather than later. Okay, so this requires a very different architecture, the screening and surveillance, than the architecture that we need in order to stop community transmission in clusters and do contact tracing. And but there's a limited resource, which is the testing availability. And so all of a sudden we have, some communities really want a lot of testing for screening, and other communities need testing just to quell the outbreaks that are happening. And so that's, there's a lot of discussion over who should kind of win out, who should get access to testing at labs. And my deep concern is that a lot of the choices that are being made are not sort of being made consciously, but kind of what happens is folks that are essentially sponsored by an institution or a corporation that wants to have screening and can afford to buy that capacity are doing so. While trying to get both screening and contact testing for contact tracing in place to try to end community transmission has less of a strong advocate. And so the accessibility issues now have really multiplied. So yes, if you are exposed or you have symptoms, you can still go to a health facility and get testing, and that's okay. But you also, if you're in a high-risk group or you're in a workplace safety situation and your company is willing to pay, okay, maybe you can also get access, or maybe not if you're not. You have, some tests, definitely the state of Massachusetts has done a pretty good job at creating these pop-up testing sites in communities that are most heavily affected, but there's still like sites you have to travel to and take some time off and, go get tested at. It's not as easy as having a testing strip delivered to your dorm room and you be able to do it and then, have it sent off to a lab. And, the issues around, there are all sorts of issues still around supplies, chains, and, whether the lab facilities have the materials they need to run the test, and whether we can get the turnaround times within 1 to 2 days. By and large, we've succeeded, but for those folks that are actually able to get the test. So, affordability also remains a bit of an issue. If you're symptomatic or you're exposed, you can get your third-party insurance to pay. However, if it's just for screening, then either your company or your corporate sponsor has to pay, or you have to pay out of pocket. And again, the issue around acceptability, I think we're starting to see a lot of concerns around should I get tested? Because if I get a positive test, will it mean that I can't go to work and make money and have a paycheck? And that's a very difficult set of conversations that are kind of before us and we're talking about every day. With respect to the quality, yes, I still think that the tests, generally can, if we can solve the accessibility, the affordability, the acceptability issues, the tests do tell us what we need to know. So, the upshot at this moment for me is that we still lack the robust public sector capacity to distribute and allocate testing in a way that really allows us to control COVID. So again, the kind of take home points from my perspective for you all is that delivery matters. It's the testing, not the tests necessarily, although better testing and better tests is fantastic. And vaccination, not vaccines, to think about. And then the AAAQ questions can help you sort of discover that invisible architecture of delivery, and that you have to think about when you're learning about that architecture, realize that is really where the disparity issues come into play. That's how they're operationalized potentially. And personally, I've become very bullish on building public sector capacity with respect to testing. I'll end there.
Thank you so much, Dr. Bourdeaux. I think this is a wonderful framework, and we will now move on to Professor Mina to round out our third discussion, and then we're going to have a robust Q&A. So I think Professor Mina is on our line here. Great.
I am. Okay, can you see those slides?
Yeah.
Great. All right, hi, I'm Michael Mina, and I'm gonna talk briefly about different testing strategies and sort of a new testing strategy that I think could help to sort of pave a road to suppress the outbreaks where they're occurring. And I'll probably go through this pretty quick so that we have time to just talk about it after. So first, I always like to show this slide because for anyone who's wondering what might be to come in the fall and winter and early of 2021, I think this is pretty illustrative. This virus that we're contending with right now, COVID and SARS-CoV-2, is of course part of a family of other coronaviruses, and we call these seasonal coronaviruses colloquially for a reason, and that's because they are very seasonal. And so the purpose here is to just point out how we can see that right now we're in September, and August and September are really the low points for a virus like this under normal circumstances, and come November, December, January, and maybe into March, we often see these different strains of coronaviruses will essentially explode at different times of the year. And so I think we, as we're thinking about the future, we have to really be keeping on top of what this virus is most likely to do based on what we know from the past, from past experience with other similar viruses. So there's a few different types of testing modalities that we can use to perform surveillance testing and outbreak control. Nucleic acid testing is what you may have heard, well, what you have, I'm sure, heard about and tried many times now. And that's, if you're on campus, and that's PCR testing. PCR is the primary mode that we've seen of testing for this outbreak so far. And the important thing there is to distinguish, or the important thing about this slide and what I want you to take away is that that you can either look for the virus or you can look for the human response to the virus. Both can give you evidence that somebody has a viral infection or has had one. And there's been a lot of confusion, but antibody testing is a way to know that somebody has been exposed. There are some different tricks that we can use to understand potentially how recently that exposure was, but it's not necessarily a diagnosis of current infection, which has been a bit of confusion for people. It's a metric and a data point that you can get from somebody that will let you know that they have recently or in the past been exposed. And so both have their place in evaluating outbreaks and being able to control and survey for a virus and to know if it's sort of creeping back up into a community, for example. But antibody testing usually comes up weeks into an infection, usually 2 or 3 weeks. whereas the virus can start to be detected usually within days of becoming infected. But then that signal will generally tend to dissipate within a couple of weeks or potentially as long as a month or two. And so these different testing modalities have different uses. In case you haven't seen what some of these instruments look like, this is what we just heard about was some of the fumbles of the early CDC response in March and February, and this is essentially the instrument that the CDC initial CDC assay was meant to be used for. This is a basic real-time PCR instrument that sits usually in a research laboratory. You rarely see these in a modern-day clinical laboratory. They're very manual. They're kind of hard to use. They're hard to set up, and so they're just not used a lot, which led to a lot of the problems with getting the CDC assay started in this country. And just to give you an example of what we use today, these are what you'd see in most modern day microbiology laboratories. In particular, these two on the bottom left. Most of you will probably never walk into a microbiology laboratory in a hospital or another facility. But these are what you might see, and they're very high throughput. They're really simple to use, hard to mess up the tests. Or you start to see some of these really point of care tests where you can like take a swab from somebody and pop it into one of these cartridges, and away you go, and you get a result really very quickly. So these are kind of what we've seen come up. Some of them have really, the technology and tools have really been deployed widely now. But the fact that we use these types of instruments on the bottom left so much, and we are so reliant on them in the modern microbiology lab, is a large part of the reason why we couldn't scale up testing in this country in any real way until these companies started producing the tests. And then what we should expect to see in the near future is these rapid paper strip tests. And I'm going to talk a little bit about these for the rest of the talk. And these are kind of like a pregnancy test. They're called lateral flow assays. There's going to be lots of different versions. Some of them are even going to be CRISPR based. But the point is they don't need an instrument. They could be made very, very simply, and usually will give results in minutes. And so they have a whole different utilization in a pandemic like this. And that's what I would like to talk about now. And so when we're thinking about test characteristics and how we normally prioritize testing as a result or in response to an outbreak or pandemic like this, these are some of the metrics we look for. And usually you can't have all of these metrics. So you might want a really sensitive test, a test that will detect if somebody just has one molecule of a virus in them, of a viral RNA in them, for example. Or you might want a test that's really fast. Or you might want a test that you can give to people every single day, and it's low cost and you can use it daily. But it's really, really hard to get all three of these metrics into a single test. If you could, that would be terrific. And we might start to see more and more of those types of things come about. But for the moment, you really have to kind of choose two of these. And so we usually prioritize sensitivity, and that's kind of top of the FDA's list for what kind of tests should be available to the public. But is this necessarily correct? Do we have to prioritize sensitivity? And the point of the next few slides are really to give you some framework to think about rethinking whole programs. And we've been focused on PCR testing, but if we just reframe the question a little bit, do we find that we have a lot more option? And so a fast test that's very, very sensitive is going to be really expensive. And that would be like one of these tests up on the top here. These can be fast, but they're expensive. They're highly manufactured. Like this one is a molecular test that has a cartridge, but it's around $60 and you really can't use it every day. But what about a test that's really fast and really expensive, but that's a lot less sensitive to detect molecules, say 1,000 times less sensitive? That would be a test like this. And would that be actually useful to us? A lot of people would say, I don't want a test that's 1,000 times less sensitive molecularly. But what if we reframe how we think about it? And to do that, we can look at sort of the biology of this virus. We can say, we know the virus grows across many orders of magnitude. Say it grows from 10 viral copies upon infection to billions or trillions in your nose. And that, when you start thinking that the virus grows up and is probably most transmissible when you have millions or billions or trillions of viral particles in your nose, then all of a sudden being able to catch 10 viral copies versus 1,000 looks a lot less important. Maybe you don't have to catch 1,000, maybe you just have to catch 1,000,000. And so would a lower sensitivity test here still be useful? And I argue that for a virus like this, it very well could be. And so we can use lots of mathematical models, and if people have questions about these types of models, I'm happy to answer them after, but we can essentially plug in a lot of different things like the viral kinetics and what we know about the virus and what we know about how people communicate with each other and move around. And we could put these into agent-based or different SIR type modeling frameworks using math and ask the question, does sensitivity matter? And what we see as the main takeaway here is that while so much focus at the FDA and other places has been placed on thinking about the sensitivity of a test, so these two tests, what I'm showing here, are what happens if we use two different types of tests in our scenarios of outbreaks. They're one is 100 times less sensitive, this 10 to the 5th, the darker one is 100 times less sensitive, and we have similar results for 1,000 times less sensitive or 10,000. Is it important? And what it turns out is that no, it's really not that important relative to the frequency of testing. And so if we ask how much infectiousness or how many days infected could we remove out of the population during an outbreak, or really this is the easier graph to look at, how many total infections relative to no testing could, if we were testing people every day, for example, and removing them from the population the moment they get infected or the moment we detect them, it turns out that both tests work really, really well. And it's the frequency of testing that's most crucial here. And so if you can take a test that's a little paper strip test that has 1,000 times lower ability to detect molecules of a virus, but you can use it daily instead of, say, every 3 weeks or every month or something, you can really have a major impact on an outbreak. And we should probably be focusing more on frequency of testing is the point. And then also turnaround time. That's another huge thing which you heard about just a moment ago from Margaret, and that's some of these tests are taking weeks to get back, 10 days, for example. And that essentially, in this model, what we're showing is the frequency is important. And then within the frequency bins, you can have a really rapid test that gives results almost immediately. You have a test that gives results in a day, or a test that gives results in 2 days. If you start to get up to tests that give results in 7 or 8 days, you may as well just throw that test away and demand a refund. And so essentially the turnaround time, these are the items that I think we really need to be thinking about much more, as sort of turnaround time and how frequently somebody can actually use the test. And so I think, well, I'll just show you this one last slide. This is if we had an emerging outbreak and it's sort of increasing, and then we start using a test. And we could use a test, say, every 3 days or every 7 days. And we could essentially, the moment somebody takes that test, they remove themselves from the population. So they don't go to work, they don't go to school, things like that. How quickly could we stop outbreaks through sort of a testing regimen like this? And it turns out that, and probably rightly so, we've seen evidence of it now, that if you could use frequent testing, say every 3 days, you could even have a lot of people completely refuse to use the test or use it incorrectly. The test doesn't need to be perfect to get what we call herd effects, to stop an outbreak. And that's because every transmission event that you stop potentially prevents hundreds of additional outbreaks down the line. And Pardis, I came in late, so I'm not sure if she discussed it, but the Biogen conference is a great example of where one transmission event can lead to thousands and thousands of cases. So say that we were able to have stopped a few of those early transmission events and stopped it right at the source at the Biogen conference, we would never have seen massive, or we probably still would have seen outbreaks, but they could have potentially been mitigated to a large extent. So the point is we can actually use testing to become the intervention to stop outbreaks in a similar way to how you don't have to vaccinate the whole population to get herd effects that can stop the outbreak. And so, so I think that while we normally prioritize sensitivity and sort of we focus so much on the test itself, we need to be thinking more for public health. We need to be thinking of what's available for the testing regimen. And that's where the frequency of testing and the speed to get results become priority. And instead of focusing just on identifying molecules, we really need to change that to focus on what's the best approach and best test to identify people who are infected rather than the molecules they're infected with. And that means that frequency and speed end up being priority. So I'll stop there. I'm happy to talk.
Thank you so much, Professor Mina. These have been 3 phenomenal and I think really complementary presentations. We have some great questions. While we're getting people to come and join us, I might ask a first question that picks up a little bit on the thread that you were just discussing, Professor Mina, and others should feel free to chime in. This was a question that was posed to me recently, and I'd love your thoughts, which is when we're doing all these tests and we have high negative rates, so large number of people who are testing negative, and particularly with these large volumes of screening now we're doing at universities, at Harvard, does that somehow, how does that relate to state data? Are we, through this kind of chain of communication, and Margaret, you might have thoughts on this too, are we falsely elevating our negative rates in the state, and how does that play out when we have all of these very intensive testing programs that may have a high number of negatives and they're repeat testers in these settings?
Yeah, so, or Margaret, did you want to say something?
You go first.
So the question of repeat testing has come up a lot, and what does it mean? How do we interpret repeat testing of individuals? Are we going to skew? I think it's a very astute and important question. How do we control for that? If we're trying to use testing metrics as to evaluate how good our public health programs are, we have to have a good understanding of what the tests are telling us. And so if we're testing, we could take it to an extreme and say one person used 1,000 tests in one day. Would that start to really skew our data? And it does. It turns out it does skew the data, at least the way that we're evaluating it. We have to control for those things. And this is something that the CDC is now we were just discussing this this week actually. How can we start to really think about repeat testing in particular of college students? Or for example, if we get these rapid antigen tests that I was just talking about, if we start using these a lot, we actually have to start coming up with new frameworks of how to evaluate it. I would say more data is generally better. And so we wouldn't want to say that it's bad to have repeat testing data, but we just have to really understand how it is that we're using the data. And we have to know what kind of data it is in order to interpret it appropriately. And if we're not taking that into account, we might, and we're expecting one kind of data, making decisions based on positivity rates, for example, without accounting for these differences, which might end up, I mean, Massachusetts is full of universities and colleges all doing repeat testing. It becomes increasingly important just to know what the data means and build our decision tools around that.
Yeah, I mean, second that, I think that number of sort of percent positivity has been a very crude number, to follow. I think as I've started to kind of understand a little bit how that data is collected, I don't follow that number. Let me just put it that way. I think there's a lot of concern about what that denominator is, who's reporting it. I think the thing that I really have a lot of time to think about, or want to devote a lot of time thinking about, is a little bit between the relationship between the test results and the support people get, the advice people get, and the public health response that is triggered with that test result, be it negative or positive. And so, what I am seeing, is that I actually am very, very proud of of Massachusetts and the contact tracing program that has been built. I think it's really impressive in terms of the way it builds solidarity with communities. It really is accompanying people through very, very tough moments in their lives where they may have infected someone else and they may have led to their death. So that is a very, profound thing to accompany people through. I think we want to make sure as we are building out our testing that we're thinking through what are the supports people need and how do they access that support and advice just for them personally. And then I also think the other question is how does that test result get reported to folks that are working the public health problem, trying to contain, suppress, even eliminate the epidemic? Do they get access to it, to that result, and what do they do with it? And so I would just say these concerns have kind of been rattling around in my brain for a couple of weeks, but yesterday I spent about 3 hours on the phone with a friend's who was trying to sort out her kid at college and a testing situation where at this particular college, which is not in Massachusetts, the students can go out and get free tests at the CVS. And so, there's this very anxious group of students who are running out and getting tests all the time. And they've had some positive results and some negative results, and they can't figure out who's been exposed to what and is anybody sick. And it's just this huge brouhaha. So I was just sort of thinking about how that is, that problem at scale. And the other thing I'm very concerned about in terms of inequities is that, there will be a segment of the population that can get access to tests that are, give them the results personally, which is awesome. But then they will very likely, a fraction of them will go and want a confirmatory test. While folks that have less money, that don't go out and don't have access to a personal test, but probably need more frequent testing or need to have access to screening and testing, they will not have access to the confirmatory testing, which is of such limited supply right now. So I am kind of concerned about how are these things going to play out, and whether it will drive disparities or whether it will ameliorate them. And that's my main concern here, is that we don't have the governance in place to set priorities. I think we've turned a lot of stuff over to the market to sort out. And I would not have done that looking back. And that's really what I've learned from this experience so far.
Thank you guys so much. We're going to turn it over to our students now, who I know have wonderful questions. So Yvonne will start to pull up some students for us.